So as an introduction, in-house sequential aligners, as presented to you by Adaptive Orthodontics, which is our new company. So we're going to take you through, in the course, scanning intraorally, then using Mesh Mixer, which is the pre-processing Kevin alluded to. This component here is one module. Then we will show you how to print the module, and with the models, make the trays, and of course, issue it. We've gone through all this before, and today, if you look at the overall, I started talking to you about the cost benefit. The overall scheme of it is definitely cost effective for us to do this. Right? Absolutely cost effective to do it. And for you to do it yourself, you will get a better feel, better control for the cases than having cases being handed to you and then you modify the treatment, which is the classical Invisalign, third-party lab way of doing things. The more you do of the cases yourself, the better your results will be, definitely. Of course, we're not talking about all the simple cases. Anybody can make that work. Even Smile Club will say they'll make it work and cut out the middleman, which is us. But I'm talking about serious cases when I do it properly. In Autoline, I did allude to last time and show you guys a little bit about it, but it is a very powerful program. You can explore many options: extraction, non-extraction, extracting between two. And I can't remember if I went through one of these cases with you. We have time today, and you can ask as many questions you like. We have time today to do exactly that, to go through a case. But I might bring forward a case to show you that that happened today. So that's Autoline, and a very, very powerful tool. Even whether you print or you don't print, the main thrust of my course is to teach you how to move teeth with sequential aligners using this software. This is the tool. Many software out there, but this is the only software that you buy once off and there's no ongoing fee, and you're supported basically for life. It is, so far, I can't complain. It's very good. Little fixes comes in all the time. Right, so it's if we do it properly, it's very responsive. Clearly, it's more responsive than waiting for a feedback from Invisalign and then to and fro. And you can adapt your changes very, very quickly. By that, I mean, we scan refinements as often as we need. Clearly, you don't want to do it too often, but we can, and we do so when we need to. It's done very quickly. And I have very extremely good staff engagement. It's really successful in my practice. All right, anyway, let's get down to what we want to talk about today, which is what happens when it gets really, really busy. Okay, and when it gets really, really busy, we use something called let me get it up for you. Clicker. So this is my home screen. Let's start with just showing you. I think I kind of showed off this part of it last week. This is my setup in all the cases I have currently. They are mostly all active here. Okay. Now, when I look back in my history of what I've done with Invisalign, I have about 50 cases, which I stopped doing that years ago now. I had 50 cases that I did. And after doing 50 cases with Invisalign, I had enough. I just couldn't organize, it was so slow. The result wasn't there. The refinement procedure was very, very tedious. it was kind of boring after a while. It was doing things by remote control, and there was not enough turnaround, feedback, responsiveness. The reason I can do this now is because I can control cases very quickly. I'm very responsive, and these cases are all live. Okay, I'll give you an example of a case that I did today, delivered today, and I only saw her for the first time last month. Okay, so this is how this case started. This is her case details. I uploaded all my data, let's say, this is my quote for her, and she accepted it. It's a relapse case, ortho relapse case. It wasn't my case, and it was done a while ago. She's got a continuing tongue thrust, and we proposed that we do this case and costed it for her, and I think it's going to be 8 months in the making. She accepted. Now the case was then put through here. This is a task, and this is how task starts off. It's in a to-do list, okay? And then I create the print file. It gets put to here. All right. It's kind of simplistic to show you, but there's more sophistication in this. When I put it here, I then also shared it with my lab, Joanne, my right hand in the lab. And when I did that, it'll show up here as well. And since I moved it, she's appeared here again. Right? And that's automatic. I mean, like when I share it, it's automatically there again. And she tells me what's been happening too. She says it's been partially made, but of course it's now already been done. And when it's finished here, which we did, we delivered it today. Tray's been made. When she made it, she put it there, and I knew it was made. So today, when she came in for appointment, I now graduated there already. I can also tell myself that because she was only here for the first time, my protocol is the first tray is given partially issued. The first tray, I only give them, the first time I only give them 1 tray. 0 is a button tray. And the way I annotate it is I say, this one is done. So when the patient turns out next week, I know that there's still trays here. Sorry, I put it in the wrong place. There's still trays here. It's been made and only partially issued, right? When they are done here, that means it's done. I've got nothing else to use for them. So all these patients here, they have trays ready to be issued. This is how I control them. Now this is not what this is the lab component of the ClickUp, right? So this is the lab in-office lab. Mine is case management up here. Now, without going into too much complexity, because looking at this, you're going to go, oh my God, what am I going to do with this? It is in fact this organization that makes it possible for us to do this in-house in a very practical and very, very stress-free way. When you originally look at it, if you don't fully understand it, take my word for it for now. Once you get into, like when you first start doing 1 case, 2 case, 3 case, okay, fine. When you start getting to 10, 15, 20, and as you know, each of these cases isn't just 1 or 2 weeks, 1 or 2 months, they're months, and some of them are over years. You need to have some way of controlling it. So the way I see my cases is I look down here. Notice they're not sorted alphabetically. They can be sorted alphabetically. I move the most active cases to the top. Okay, I move this to the top, this one to the top. This is a very interesting case that came back today. She has been down in the ski field for the last 6 months, 8 months. And before she left, I started the case and I gave her carrier appliance, which is something I'm very, very very. I'll show you that this case actually. I'll allude to it straight away. So this is my website as well, and when you join a course, you can start your own account on this one, and this is the cases. Hang on. So Eleanor is a very class 2. There's a crossbite there as well. Extreme class 2 case. Class 1 on this side, class 2 on this side. A very challenging case, even with, it's deceivingly, how do I say, it's deceivingly easy, but it's quite hard. Now, she disappeared on me for how long? Let me see. This is starting and the date was the 5th. So 6 months. Yeah, 6 months and a couple of days. And she came back from the ski fields today because she's like she works in the ski fields. And what we've done with the carrier appliance is corrected the AP, anteroposterior relationship is done. Now, all left for me to do is correct the crossbite and close the gap. Okay, and I took this off, this appliance off today, scanned this. How fast does it take for me to close one of these things? Very, very quick. I'd reckon maybe 10 months, the spaces will be closed and the crossbite will be fixed. So if you include the time I put this in here, 10 plus 16 months, that's pretty cool. But if she had come back earlier from her ski field and the COVID lockdown, I would have finished this much earlier. Yeah. And the button designs are very interesting. So,
Michael?
Yes.
Just that case with all the gaps in front, and you don't have much room down the lower arch. How are you going to close it?
I got plenty of room in the lower arch. There's plenty of room in the lower arch.
There's no overjet. It's touching already. Like,
no,
can you go back to the picture? It's not?
Yeah,
I can't see it.
The picture was a bit deceiving.
Okay.
But here's the thing. If it is or it isn't, we'll soon find out, because long before I get there, this is a digital setup, isn't it? No, that's not touching. It's definitely not touching. I already set this up before we did this. Let me just see if I can find out the case for you. So that's as opposed to when you do analog wires and whatnot. You put the wires on, and some people ask you to measure this, and that's like really. When you do it this way, you don't have to measure it or whatever. You just move it in the right positions to see if it fits. And more often, you already know your results before you get there. Let me see if we can find it. Yeah. So this is my trial. This is her, right? So initially. So I already know this can be fixed, but you think you're going to get this kind of movement with Invisalign does it by putting slots in the trays and using class 2 elastic. Yeah, Joe, is that right?
Yeah, yeah.
They put slots in the trays and then they put a hook here, whatever.
Mm-hmm.
I mean, I tried it. It's ridiculous. I mean, it pulls the trays up. So the carrier concept is very, very smart. Divide and conquer. We fix the AP correction, which is the hard bit. And once the AP correction is done, closing the gap is 2 seconds worth, right? And the AP, this molar movement here, this one here, just getting this bit all the way up to here, everything forward. We actually didn't move this one forward. We moved this component back. That's why there's gaps in front, right? So even though I set it up to go this way, it's more to show her this is the result I'm going to give you. But I knew immediately when I saw the molar discrepancy, I said, I want to put you in a carrier appliance. And normally 4 months is enough, right? But because she was away and there was a lockdown, nothing I can do, I said, just keep up with it. Because as soon as it went into class 1 relationship, it locked in, it wasn't going to move much anyway. And if it did, after a while, there will be some relapse. So I'm very comfortable. I said, keep going, that's fine. And I hadn't seen it for a while. So this correction here, seeing how the mesial of the 4-6 is now in front of the 1-6, right? That to me is fine. That might be a little bit of relapse. You see, this has gone forward a little bit as well. Why did I do both sides? It's a kind of unknown thing. You can't pull on one side only, it'll be out of balance. You pull both sides. Whatever this is, it'll become a bit of a relapse. It'll go back into position. But it didn't move much because it was really locked in, right? And that carrier, the use of carrier is something that I would promote very much in my course. AP correction, class 2. I've got even a class 3 case of this. Let me show you. And I don't know. The funny thing about when I used to do fixed appliances, I took heaps of photos. Every month I would take a photo. Right? This is a very, very interesting case. This guy is like this, presenting like this. He's class 1 10 years ago. Do you know what caused that? Snorgard, SomnoMed.
Oh, wow.
A mandibular advancement device. That's why now SomnoMed. I love SomnoMed. I use it myself, but this guy was kind of severe. SomnoMed now uses the appliance, and every morning you have to wear the deprogrammer. The deprogrammer. And luckily, he's a long-term patient. I said to the guy, I said, listen, I'm sure your teeth wasn't like that. And because I routinely take photos, for just intraoral checkups, I'll flick back and say, there it is. You're not. This is not correct. I said, can you move your jaw back? I thought it was postural. It's not postural. And when you look at it now, you can see all the angulation. The lower teeth will be tipped forward. Anyway, this is a very, 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 very long term. I just look at the right hand side, right? You just follow this. Now, at first, I very naively thought that if I just use the sequential aligners, that the bite will slide back. Then when I realized, forget it, it's not going to happen, I use the carrier. Motion 3 appliance. I'm going to skip to as far as I can to the forward now. And you see, I've basically got the nearly class 1 relationship.
Did you do the carrier with the aligner together?
Yes. So from here to here. Good luck doing it any conventional way that quickly, because I mean it wasn't that quick, because you have a look at that and you think, oh, that wasn't quick. It's actually quite long. Yeah, it was. The carrier appliance took a long time. Where is it?
18 months.
There you go. So the carrier appliance, when did I take it off? Sorry, I should have locked this one in. This is my tool, incidentally. This is something I developed. And so I'll lock this one in so it doesn't move. So you see on February, a year later, I think a year later. No, not even that. Okay, there you go. 7 months later, it was still on. And then next time I took a photo, which would be when I took it off. So that's 8 months. That's quite long for carrier appliance. Carrier appliance are usually quite quick. So look at where the lower arch is gone to. It's created gaps here. Okay. Let me look at the left side too, if you like. That's a lot neater. Now you'll note, I do recognize that the teeth are still leaning forward, okay? But at this point in time, we're going to suffer burnout. The reason this guy is has got this problem, he really needs his Somnomet. So do I. I sleep with Somnomet all the time. I'm a horrible snorer. And he is too. We're willing to put up with this until I fix his teeth before we go back to Somnomet. But that is an incredible, I don't know how much ortho you've done, but to get this fixed in, what is it, let's say 8 months, the anteroposterior fix is quite incredible. It's quite amazing. So,
so Michael,
yeah,
you would treat the arch where there's only just the button, and then the other side with the bar, you will just do the bar without the aligners. Is that correct?
No, both sides has to be done bilaterally.
Yeah, I know. But say in this case, you didn't have any aligners on the bottom because you can't, because the bar is there, but the carrier thing is there.
Yeah.
Yeah, and then the top one, you do the aligners just for anchorage, yeah? That's
correct. Yeah. To bind all these teeth together. The other way to do this is actually to stick a tad up there. I don't like that.
Oh, you do? Oh, tag?
Yeah.
Oh, okay.
Yeah, I actually tried the TAD once before, and it wasn't that, it was the morbidity that discovered. So that was
put
before.
A button on top. Did you just put a button on top?
Yeah, there's a button on top. And ever since doing sequential aligners, I mean, this is the other technique of using it. If you look up carrier appliance, they will have this, or they will have TAD in there. I mean, if you're severely wanting this to go back, TAD's the way to go. That's no, even with this on, the anchorage, there will still be some movement of the teeth. You can see the interior, the upper has actually tipped forward a little bit. Right? It has a little bit. It's fine. All right. So when we talk about sequential aligners, ClickUp, today's talk really was about introducing you to the concept of, and you won't fully appreciate this. And that's why I say I'll touch on this just to let you know that at the end, the aim, of course, is to get all of my people to my course to be doing a lot of sequential aligners. And in order to do so, you must have in your system the ability to control all these cases. Otherwise, you might as well use Invisalign and do about half a dozen cases a year. I'm planning to do an average of about 100 a case a year comfortably, and I'm talking big and small. They don't all have to be big cases. I mean, big cases are fun, but they take a lot of work to do. Let's have a look at this. Yeah, he hasn't come in yet. He hasn't come in for. But see, all these cases on the top are the ones I'm doing right now. This one was delivered today. This one was, right. So let me just then have a quick look at this one to show off again a small case, which is not insignificant enough. I think I charged 3 or 4 for this case. And you have a look at the, all right. So this is an interesting case because it's got 2 implants, and the software can fix that. Or actually I didn't even segment it so that it doesn't move. Okay. This is a case that looks like this. Do that. Okay. So the top, his anterior is destructive, and he was destroying his top teeth. You know that? So I proposed to him. I said, look, it won't take me very long to fix this for you, but if you allow me to, I will align the teeth so that this no longer touch. Okay. And he saw the point of that. I said, fine. 15 trays at the bottom, 7 trays on the top. Again, you take it back to the bench mount, which is the Invisalign case. And I think this would have to be, what is it, 15 trays? I can't remember now. Let me just have a quick look.
14 is a light.
It's a light, is it? Well, it's 15.
14 is a light. 15 is 1 over.
Yeah. So 1 over, you're in I'll get you up there. Yeah, 14 is a light. You really do know your stuff. So it's a moderate. So it's a right on there, you're paying $110 per tray. Right? And again, I say to you, simplistically, I just divided the fee by the number. It's not that easy. Yeah, I'm not meaning to con anybody, but when you do it yourself, you do have to do the setup, a couple of hours worth of work, and then you have to print the thing. But with the manufacture of each one of those things is like $12, $12.50. Right? Now you send it away and get Kevin to do it. It'll, you know, it should be better than that. It should be closer to this. Now, when you come to the comprehensive case, and they're charging this much fee for it, and the minimum tray is 27, the cost does go down, right? So you can actually say for all the big cases, you can send it to Invisalign if you like. But I put it to you that all those big cases is the one that you have to do at home, because if you don't control it properly, you'll be spending, as your experience may or may not be, too much time bloody doing refinement, because it doesn't track properly. It doesn't track properly. And I put it to you that when you do it yourself and you design it yourself, and you in fact even prepare the tray yourself, it's much more accurate. You know, if you think about this for me, Joanne, if you stuck a tray into a mouth that has got undercuts everywhere, okay, you make mouth guard and whatnot, you block the undercut yourself. If you block it too much, it goes in, click, click, very easy, yeah. But if you block it that much, the tray is no longer tight. So it's a balancing act between ease of taking in and out and moving the tooth very, very accurately. And therein lies the necessary part of pre-processing the undercuts. This part here, mesh mixer. It is not a trivial part of the whole exercise. Excuse me. I spend enough time now with this component to realize that if I spend just a little bit more effort on this part, the comfort for my patient is really high without compromising the efficacy of the treatment. And when somebody else is doing, I don't know, I'm thinking, really, you think you're going to get that sort of accuracy? Yeah, maybe not, right? But I have some experience, some tricks to show people how to do this really well, okay? I've just recently did a case, which I think I might show off to you to show you. And if you appreciate the fact that, let's see, this one. What do you think the taking a tray in and out of a set like this would work? This is a horror case to make aligners for. Can I tell you from my experience? All these spaces are horrible to work with. Okay, horrible to work with, and I already blocked them out. Okay, he's got. I'll show you the original pre-processed . Yeah. This is what the bottle looks like to start with. And believe me, I'm a good scanner. I can scan quite well. This is a horrible, horrible case to work with. You throw a tray in here into this undercut, yeah, you know, you'll be pulling his teeth out to take it out. So the preparation for this before I even started moving teeth was quite extensive. Okay, so yeah, that's part of it. Once you do that properly, and then you're looking at this scenario, when it looks like this now, well, that's simpler to move because I've blocked all the undercuts out, and you know, and I already costed this already anyway. So there's 23 trays maximum at the bottom. Only 18 trays at the top. This is like a, I think I'm charging him because he's done, oh, incidentally, this is the other way of blocking out the tooth. This tooth has perio, this one's an implant. That's a tool that Autoline gives you to lock, bolt these two down. It's not actually, the shape isn't like that. It's just that for me to tell it, don't move these ones. Okay. And when I read my design for buttons, you can see these buttons, there's no price for guessing, right? These are turning, these are anti-clockwise, anti-clockwise, anti-clockwise. This is clockwise. See, that was clockwise. And my button designs are very, very natural and very, very easy to interpret. Because I think I only use, well, no, I think I only use one tool and simplistically, and they work. Yeah. And again, this case here is yet to be accepted because what I've, and with the CBCT, which I use CBCT, notice I didn't touch this at all. Okay. If you look at his original, this guy is a very, very thin tissue type. There is no bone around that crest at all. There's hardly any here. But I can't put an implant in here for him without major bone augmentation, grafting, blah, 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 which he doesn't want. So we have compromises. I cannot build you a denture when there's gaps everywhere. So what I did was I said, I'm going to give you, close this gap and then build you a denture based on this. And I decided not to turn this, not to rotate this because there's no bone here. So that's the kind of planning you can do because what? Because you can. All right.
Michael?
Yes.
So 23 trays.
Yep.
That will be just under a year.
Yep.
How much would you charge?
This case, because of the implant, etc., I probably would have charged about 6.5, between 6.5 and yeah. That's minimum. What I would charge is that's a minimum 6,005. I don't think compliance is going to be an issue with this guy. Remember, once I'm printing the stuff here, it's every 2 weeks I put it in, put it in, put it in. Yes, account for the fact that buttons falls off and blah, 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 whatever. I now spend, not like back in the old days when, when I was doing Invisalign, I spent a lot of time. I mean, this could be tidied up a little bit better. I spent a lot of time placing buttons and making sure they're on properly.
Okay.
And it says, I am not actually quite happy with this one. So while you're here, I might as well, I can show off a little bit. I did this very quickly for just to present to him to say, hey, like the numbers are roughly there, so I can give him the cost. So this is a tip one, is from the top, because I wanted to align the roots. It's more parallel. Right, and move it easily. I use this tool here to have better control. And that's it. Now I always align the gingiva. So this thing's been worn every which way. So for this one, I want to maybe intrude a little bit. Right. If you want to see where this one used, and this is the planning tool, right? I've moved it here. Is it realistic? Is it realistic? Put it back to where it was. Yeah, I suppose it's realistic. That's where it was. So I'm going to swing this thing around that far. Yeah, it can be done. Okay. All right. What else can you want to see, guys? Okay. The tools for making this, I think Kevin wanted me to show you more of this tool. Okay. Let me then show you how I worked this one, because this was a difficult case to work with. How I worked this one was, let me open up the block lowercase, and I'll replace it this one. All right, so this is the model all blocked up. Okay. I will put back the, sorry, this is the better one, sorry. See, this one here was so blocked up, I can't see any tooth left. Yeah. So I said, no, that's not good enough. So I did this, which is better. And there's a technique to doing that, was I took the first block. This is much better because I can see teeth. If you can see teeth, then your trays will fit around this tightly and you can move it around. But I've blocked the undercuts. So the way I did this was I blocked heavily. I used this version here. And this is something you guys can do, Kevin. And then I superimpose back the original. So I'm putting the original one back on there. And with the block one, I slowly don't pay too much attention to detail, the thing. So I slowly re-expose the natural tooth while keeping as much as the block as I can. Does it make sense, Kevin?
Yes.
Yeah.
That makes sense.
Where's my takeaway tool? So I push all the bits away. Now, because when I make the tray, I want to touch the natural teeth. The rest of the stuff is just blocking undercuts, but I want to see the natural tooth. So when I'm finished with this, I will combine these two, which is how I made the final one. I combined the two and then said, this is the one I want, right? So push all of these away. Now, hopefully what I'm doing is making sure that you guys know that these tools, this is what you're going to learn in the course, is how to make use of these tools. Anyway, you play with that and you strip away all the tooth surface that you want to control the movement with is back, and everything else is undercut. Right? Everything else is undercut. This one, sorry, this is the one.
Because the last time I had a case similar case, but the customer, the dentist want to make some space in the posterior 3646, 3545 area to place the implant, and he want to make a little bit straight, but also adjust in the midline. And at that time, I tried to make the aligner, it's like a space in between like a 3-4 and 3-6 and 4-4-4-6 or 4-5-4-6 area because of distance, and also the aligner came out with the wrinkles and with a very, very strong one, and also it does not have any good retention in the posterior from 7 or yes, it was like it was a 7 or yes, number 6 tip in the posterior. So there was like a big headache.
Yeah,
and actually
so this is the technique to do it, because then you block what you want to block and you expose what you want to expose. And if you want to do it neatly in one go, forget it. My technique will be block everything as fast as you can and come back and strip the strip back to the tooth, and this works well. Right, anyway, you get the idea. I strip down to as much as I want to see the gray bits of the tooth, which means that when I make the tray, these ones are the ones that are going to these are the ones I want to see, right? The more tooth surface I see, the better, but I don't want to see undercut. Yeah, and I know what you're saying. When you have this area here, if you don't block it, it becomes like wrinkle, a fin, and that's very, very hard. It makes a little fin.
Yes, and also it doesn't have like the aligner from the number 6 area, and it's putting like a wrinkle back, like in a bounce. It has like a bend, so it doesn't have any retention to hold the posterior area too.
Correct.
So at that time, I talked to the dentist, and dentist said okay with the wrinkle, but he want to have retention. So what I did was, after I vacuum format down, I left the machine over 2 minutes. I measured the time.
Yeah.
Left over 2 to 3 minutes until completely cool down. I removed the aligner from the model, and it was okay. It has a retention on the posterior.
Okay.
But if I when I took it back, like right after a minute later, but actually it lost the retention, and it is bent back. It doesn't have any retention to hold posterior.
Yeah. So I put it to you because I now know what it takes to block these undercuts, Joe. I'm not sure because I block all these undercuts with so much effort, and I know I get great results from this. It's very rewarding when you give the patient and you go click, and it fits right in, and not too much of a struggle taking it out. That's just coming for experience, yeah. But when you take it from Invisalign, and Invisalign invariably they do fit. Do you think they go to this much trouble to make sure it fits, or they just make it so loose that it must fit? So I don't know. I don't have enough experience. 50 is not enough to say. Like if I did 1,000, I'll say to you. People usually don't complain too much. It's fine. But right now I really appreciate whoever can do this block out properly, even before you move the tooth. If you block it out properly and still have enough tooth surfaces exposed, you're going to get a good result. With a difficult case, diastemas are horrible situation to have. So next worst one are people with perio. All right, people with perio, long skinny undercuts, really difficult. I'll show you an example. And these are another challenging case when they have yeah, and not only long gaps between teeth like that, right? Not only that, abfraction lesions. Those things grab like nobody's business. You have to block them all out, right? You have to block them all out. And the one I just showed you before was a more challenging case, but this is what it should look like when you finish. Looks like somebody else's mouth. There's just enough undercut. Might, you know, neat, smooth, probably too much undercut still, I think. But, you know, long, skinny tooth with gaps everywhere. Yeah, so that is part of the course. And then the other thing too is to show you, which I meant to show Sky and another cool tool to use. And I just have to look at the case now to show you. The one I just mentioned before, I've generated it.
Sorry, Michael.
Yeah, go ahead.
When you do the, sorry, when you do the undercut, block at the undercut, is it just a tool to you just press and then all the undercut is blocked out, or is this like an eraser that you just fill up the thing?
There is a way of trying to do that in one mask like that, and I don't like it because you don't actually know which one is taken up, right? I manually go through and pick the undercuts up.
So you're just coloring in, basically.
Let me just show you quickly. You don't, yeah, it's kind of like coloring in, but you kind of add it on. I'll append so it sticks on top of it, right? This is a very, very powerful tool. Okay, let me tell you, it's so powerful that that I don't necessarily know how to use all of it. Okay, so this is this. Right, so here I would use Sculpt. I would use. You could just add like this if you want to. I use the Bubble Smooth, which is quite good, and control the size of the affected area. Have a look what happens. Okay.
So makeup is added.
Yeah. Makeup. Yeah, you can call it that. And see, you can go right in the bottom here, right? These are all undercut. I sink it to the bottom so you see the whole thing shrinks in. Press the button. There you go. Right. In the future, I'm pretty sure, I mean, if it's up to me alone, no more plaster bay for me, really. What, you know, when you do anything and you want to block undercut, we used to just stick our finger and do it in the analog way. This is much more precise and you get much better fitting trays. They fit so well. Right? This is just one of the tools. And at first, your first course with this is all you want to do. Just go around and do this. Look, you'll learn very, very quickly. If you don't block enough undercut and you have a case where you make 6 trays and you go, oh shit, the patient clip it on and yeah, you want a crowbar to take it out. You learn very quickly to more efficiently block the undercut.
Or you can't even get it out the model.
Yeah, correct. Well, that's the first clue already, right? So my Josephine, not Joanne, my Josephine will should actually come and curse me and say, you didn't block undercut. or not block enough undercut. Now, what I have said to her was, eventually I'm going to teach her to do this part, because clearly, if you don't do this part properly, in the making of the tray, you suffer. So you might as well do this part yourself, because you know if you do this properly. Now, I'm also trying to keep the area, the bubble here, as close to the interproximal as possible and not touch the buccal surfaces, because anything that I don't touch means that the tray will adapt very, very accurately. Correct?
Mm-hmm.
Right? If I go and touch all this and make it bigger, it'll be loose, or smaller, it'll be too tight. And that's why I say to you that I suspect sometimes that in order to make their tray fit faster, any lab technician would obviously want to make everything bigger. Here's a little trick here. This is here, different tool. I use the pinch tool for this. Right in the middle, pinch, close it up. And then go back to the other tool. All right, anyway, that's boring. You don't want to watch me do that. It's quite therapeutic. Okay, for those of you, let me just say from the outset, for those of you who think that doing this is going to save you lots of money, okay, it does save you money, but it's going to give you lots of time. It's not, right? It's going to take you time to do this. It doesn't save you money without you putting the work into it. You will do the work in it, but what the impetus, the reason for doing this is you're going to do better than orthodontics. You're going to do, absolutely. I now love orthodontics. I mean, I went through a phase where I did orthodontics. Oh, I put wires everywhere. Hate the wires. When sequential aligners through Invisalign, it didn't take me long to hate. Right? This one I love. The results are very, very much more predictable. Okay. No more questions, anybody? I've lost John already, have I?
Good, okay. And you can show more during the course. And also I will talk to Dr. Sang to join the course.
Yep.
Okay.
All right. Anyway, I'm wasting my time because there's nothing here. I've already done this.
Yeah, you don't have to do anymore.
Yeah, so I've already done this. All right, Joe,
okay.
Come to the course. I'll see you then.
Sure.
Oh yes, Dr. Sang, I will call you tomorrow morning to discuss the course and your associate dentist too. And
sure.
Yes, Dr. Hall, thank you for your